when you get your reports back. So of course, I think as busy clinicians, I always feel that we just want as least headaches as possible when we get a report back, and we want to be bothered by as few discrepancies in gender as possible. And certainly I would just put it out there that there are differences in the sex chromosome, sex gender discrepancies using different methodologies, different NIPT methodologies. So this is what we try and avoid. So this is like I get these sort of texts every 4 to 6 weeks, you know. Somebody will text me and say, hey TC, you know, I've got a problem, you know. That's when I usually hear from them, maybe 2 months or so. And then they'll say, oh, I've got this problem, you know, I've got this patient, you know, the patient's had NIPT, the gender is XX, and then I've sent her for a scan and it's a boy. What do I do? So, and then the second point I make is that, you know, what should I do? Should I repeat the NIPT, or am I missing out something else? So my reply is, well, look, common things occur commonly. It could be a vanishing twin, it could be a lab error, it could be a typo error. Better to ask the patient to feed back to the lab. This NIPT was done in the UK, and so I suggested that they should write back to the lab, ask for clarification, because there's something obviously not right there. And no point repeating NIPT until you've got clarification as to what's going on. So the clinician gets the patient to contact the lab, and then what happens later? Well, the lab replies, and I'll leave you to read the reply, but essentially it's a transcribing error, okay? So maybe we'll just read through it. So I think it's very good, actually, the way they craft it. I think we can learn a lot from the language. This is obviously legal heavy, and very good at covering the, you know what. So it's very good. It says, oh, I attached the original report, we had received it from NIPT, it indicated that there was a Y chromosome, and therefore you are indeed having a boy. But looking through our records, blah, 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 we realized that you wanted the gender to not be revealed again, you wanted it revealed, so we understand there was a change, and we wrote it down, and the lab reported a boy, yet for some reason, our admin team erroneously entered a girl on your report, on your record, which then got pulled through into your report that you were given, which therefore again incorrectly reported a girl. So I think this is quite good, isn't it? We must learn how to say this. We're just not smart enough. So anyway, we must learn from this. Okay, so anyway, typo error. 2 words, typo error. It happens all the time. But of course, to be fair, it may not be a typo error. So the point 3 to 5, I'm just trying to talk us through what happens when you have that situation. Get the lab to check, get the NIPT lab to check. Okay. Next one is to get your ultrasound department to check and make sure they haven't assigned the gender incorrectly, because you know it's just as possible the lab got it wrong or the ultrasound department got it wrong. Yeah, and I'll show you some data to suggest that later. And then you come to the last point, which is when there's a persistent discrepancy, then you refer to your MFM colleague, whereby they'll need targeted sonography, and almost certainly they'll need invasive testing for CMA and whole exome sequencing, but I'll come to that later. So this article, this paper published by Damenka and colleagues in 2020, I think gave us quite a lot of useful information on this. This is a large study. It was based on SNP-based technology, so it was a Natera study that reported data on Panorama. And 1.3 million patients were studied in this study, published in the Green Journal. The aim of this was to look at the very point which I've been asked to address today, which is to look at the fetal sex discordance between NIPT and ultrasound. They looked at about 1.3 million patients over a 5-year interval. And of course, there was some exclusion criteria, to be fair. They excluded patients with high risk for aneuploidies, sex chromosome aneuploidies, egg donors, and surrogate pregnancies. And the outcome data was a bit mixed. Okay, it's not a perfect study by any means, but the outcome data included ultrasound reports, diagnostic testing, and other clinical observations. So in this 1.3 million patients that we studied, I think what's really interesting here is that looking at the last two, yeah, of course there were some that were lost to follow-up, about 7% had insufficient data but normal outcome. But I think it's the last two that we'd like to concentrate on. About a third were due to human or methodological errors. So this is the group that I alluded to previously. And about half are true disorders of sexual development. Let's go through this in a little bit more detail. Of the 30% that were human or methodological errors, about half were due to mislabeling on the phlebotomy side. So something was labeled wrongly when they did the NIPT and when they transcribed the results to the report. Just as many were actually due to misassignment of fetal sex by ultrasound. Yeah? So they both contribute to the errors that we see sometimes. 3 were due to IVF fetal sex labeling errors, and it's the bottom line that is the true errors, laboratory error or the limitation of the NIPT where the sex was assigned wrongly. Now, this is actually, that leaves us with about 50% or more where there were true disorders of sexual development. And I'll come through this later. About 19 of those were due to 46XY disorders of sexual development. About 4 were 46XX disorders of sexual development. And there were 7 cases of sex chromosome disorders of sexual development. The 7, I can tell you, were about 6 of the 7 were actually Turner's or Turner's mosaic results. Now, what I hope to do with the next slide is just to help you to triage through what you would do if you had a patient in this scenario. So first of all, you have a discordance. So what you do is you confirm the ultrasound findings, preferably by getting the patient to go back to the ultrasound department, get a second scan done by another sonographer or sonologist, see if the results are concurrent with the first report. You call the lab up, and most of the time you might have to do a second draw and send the sample for a repeat NIPT. If you solve the discordance, that is to say that there was some error earlier on and it's been rectified, then the patient is then managed as per normal. But if you fail to resolve the discordance and the discordance remains, that's when you refer your patient for a consult with your MFM colleague, and there will be a workup that has to be done. Now, it's the last part that is critical. If you look at the next slide, right at the bottom box there is you've not resolved the discordance and you're left with this situation where you have to send the patient for a further consult with your maternal fetal medicine colleague, almost certainly with the geneticist as well later, when you have the invasive results back. And then you have an issue because you may still be unable to resolve the findings between the two, and that gives rise to a whole area of concern as to how you would assign the sex of rearing when the baby is born, which colleagues you would have to get involved in the care of the newborn after birth as well. So I'm just going to, this is probably the most important slide. And I'm sure our good friend Tony will dream up some amazing MCQs to ask you next time when we do the MCQs for accreditation, which the college will do for us. So anyway, look at this is a very, very helpful slide. I think you will find this very beneficial to have available. So the problems, these two boxes are a bit, well, I wouldn't say easy to explain, but it happens. And could be due to a vanishing twin. So let's start with this box here. So you've got a cell-free DNA that is NIPT male. You do a karyotype, it's female, and the ultrasound is female. So how do you explain the fact that the NIPT assigned the wrong gender? Well, it could be that there was a vanishing twin to begin with, and that there was DNA from the demise of a male fetus that was present in the first trimester of pregnancy. It could also be due to the mosaic system. Remember the slide I showed you where the placental DNA and the fetal DNA was discrepant? You could actually have a placental mosaic system with the 46XY cell line in the cytotroph class that could have contributed to this discrepancy. Conversely, we look at this box here. So your NIPT was a female, you did a karyotype, it was male, ultrasound male. So how do you explain this discrepancy? So the cell-free DNA gave you assigned the wrong gender, assigned female incorrectly. Well, this again could be the other way around. It could be due to a co-demise, co-twin demise of a female fetus from a vanishing twin earlier, or a fetal placenta mosaicism with a 46XX or 45X cytotropos, contributing to this false a female NIPT result. These two are more vexing, these two boxes here. I think so let's talk through this one. So your cell-free DNA says male, you do a scan female. So and then you end up with a karyotype invasive testing and it's male. So how do you explain the apparent female genitals on a ultrasound? Well, it could be due to the feminization of a male fetus, and that's usually, it could well be because that we are not able to spot any severe hypospadias, or we could maybe assign ambiguous genitalia to the report. We just can't see clearly. So this could well be a possibility, and I'll show you an example of that later. It could also be due to a single gene disorder, like Smith-Lemli-Orchid syndrome, that can cause this. Again, I'll highlight that later. Or due to androgen receptor defects, so whereby you have the failure of the, or rather deficiency of the 5-alpha reductase. In this particular box here, you have a cell-free DNA female, but your ultrasound says male, your karyotype says female. So in this particular scenario, it could be due to extra androgens, whether exogenous or endogenous. So it could be giving the patient exogenous androgens, but I think you would know that anyway. Or it could be endogenous due to congenital adrenal hyperplasia or an androgen-producing tumor. So here we have masculinization of a female fetus. Some examples, get a bit heavy. So we have a patient who's referred for ultrasound scan, and the patient has some cardiac defects. There's also evidence of post-axial dactyly. Comment is made about ambiguous genitalia and some syndactyly. Well, one of the possible differential diagnoses here is actually Smith-Lemli-Orchid syndrome. Because usually we would see other features as well. We would see some evidence of growth restriction, maybe microcephaly, hygroma, hydroxypitalis, or clefting. In this particular scenario, you would need to offer the patient an invasive testing and do a whole exome sequencing to get the diagnosis of Smith-Lemli-Orchid syndrome. In this particular patient, the patient presented actually with ambiguous genitalia, which then led to the referral for level 3 ultrasound, and then other abnormalities were discovered. So one of the possible causes of female masculinization of a male genitalia. The final example I would just bring up before I finish my talk is a patient who was referred to me by one of our colleagues here, looked after her, did an IVF for her, and she got pregnant. She's 38 years old, as you can see from this report here. This is a Harmony report. She's 38, she went for her NIPT Harmony test at about 16 weeks, and so a low risk result, low risk 3 trisomies, and the fetal sex reported to be male. And then the patient was sent for a 19-week scan to another colleague, and at the scan, it was reported that there was a discordance between the gender noted on the scan, which was female, and the report on the NIPT, which was male. So in that scenario, our colleague counseled absolutely rightly that the patient may wish to consider having an amnio for PCR, microarray, and the whole exome sequencing, and that was done at 19 weeks. So by the time I saw her at 21 weeks, I had only the PCR report to look at, but be that as it may, the PCR report concurred with the Harmony report, and this was the scan showed, the PCR showed a male. So I saw her at 21 weeks, and did an anatomy scan, and I looked at the genitals. Of course, maybe because I saw her at 21 weeks, I see what looked like a scrotum and a penis. So I wrote down my findings that I thought that the penis was visualized, and but the penile length looked a bit short, and you can actually, there are actually nomograms for penile length. And at 21 weeks, the average is about 7 to 8, but this is such a precise science. We measured the penis and the length. I said it was 6 mm, it might be a bit short. I was trying to hedge my bets, and anyway, I reported what I found. I thought it was a male genital. We were waiting for the microarray and the whole exome sequencing, and I suggested the patient come back later. By the time I saw her, the clinician was getting a bit worried, and we sent the patient back 2 weeks later, 23 weeks now. Could still see the penis, still a bit borderline short now, 7 mm, but it's definitely visible. So by then, the microarray and the exome sequencing results were back. Microarray results were normal. There's no, sorry. There we are. This is the microarray result. The microarray was normal, no copy number variation related to the described phenotype. The whole exome sequence result gave us a variant of unknown significance. So again, makes us heart drops, what are we going to tell the patient? But thankfully we have pediatric geneticists to help us there, and that's the whole point of situations like this, where we get our colleagues to help to counsel the patient. And the variant of unknown significance was a bit of a curveball, but whether it's related to the phenotype issue that we have identified is difficult to say. Be that as it may, we brought the patient back at 29 weeks, and by that time I was quite convinced that there was some evidence of hypospadias, because you can see the scrotum, but the penis was not in the usual position. And I told the patient and the referring clinician there was a high risk of hypospadias, and therefore we definitely need to do a lot more follow-up work on the pregnancy afterwards. At the end of the time, and this is actually a report from the geneticist who wrote back to the referring obstetrician after the counseling just done at 23 weeks. So basically summarizing the concerns that there was a variant of unknown significance, difficult to know whether this was related to the pathology at hand, no genetic testing or biochemical testing recommended at this point, but a postnatal evaluation was recommended for diagnosis with a referral to the endocrinologist if appropriate, if there was true gender ambiguity. Anyway, the patient delivered at about 35, 36 weeks with fetal growth restriction and hypospadia. So just talking through this, I think you can see the challenges that we face as clinicians as we manage patients with such sex discordance between the phenotype and the genotype. And I would just like to thank the audience for your patience in listening to this, and I hope it has been of help to you.